Hello, everyone, and welcome to the AMCI E&M series. We've designed this series to break down the E&M guidelines into manageable, digestible nuggets to ensure that you have the best possible learning experience. We encourage you to watch the playbacks as many times as you need until you fully grasp those guidelines. And if you're seeking CEUs, simply click the link in the description to enroll in our online course. All right, that was kind of rude. If you didn't know, I'm Mrs. J, the Curriculum Director at AMCI, and I'm absolutely thrilled to be here with you today. Now, let's go ahead and let's take a moment to introduce our fantastic team. And we're going to start with Miss Tamika. She is our Assistant Curriculum Director and Resident QHP. Yes, she is a physician's assistant. Now let's turn our attention to Mr. Sandeep, who is also a lead instructor at AMCI, and he is our resident pharmacist with a master's in pharmacy. And introducing our dedicated AMCI approved interns, Miss Dolly, who holds both CPCA and CCS certifications. And last but not least, Miss Jasmeet, who has an MS and a medical background as a CNA. And with such an incredible team by our side, we are excited to dive into these E&M guidelines together. So without further ado, let's get started on this journey. And this is a 4-part E&M series. Yes, we will discuss in part 1 the AMCI annotation technique called CHUN. We're going to teach you how to CHUN your E&M section. We're also going to learn to code office visits and scoring the medical decision making in part 1. In part 2, we're going to discuss inpatient coding, hospital observation. We're also going to talk about consultations and emergency departments. Part 3, we're going to talk about nursing facility visits, prolonged services. And part 4, this is where we're going to summarize all of it and we're going to test your knowledge. But rest assured, throughout the parts, we will be testing your knowledge. And finally, keep in mind that we will consider the 2023 guidelines and apply them every step of the way. Now, let's get this started. Let's begin with the copyright. CPT is copyright of 2023 AMA. All rights are reserved. CPC is a registered trademark of AAPC, and the credentials CPC, CRC, COC, CPMA, CPB, CPPM, and CPCO are all owned by AAPC. The credentials CCA, CCS, CCSP, RHIT, RHIA are all owned by AHIMA. And keyword concept FTR, CHUN, AMCI Fab 7, AMCI ICD-10 CM Flip Tap, and MCG Manual are all trademarks of AMCI. So let's get started and talk about what to expect for tonight and the coming weeks. Week 1, that's today, we're going to discuss CHUN, coding office visits and scoring medical decision making. Week 2, we're going to take a deep dive into the 2023 E&M changes as they pertain to hospital, observation, ED, consultations, and nursing facilities. Week 3, we'll continue our discussion of the 2023 changes as they pertain to prolonged services, critical care, case management, care plans, preventive medicine, standby services, newborns, deliveries, and telehealth. And finally, week 4, we're going to test your knowledge with application to practice. In other words, we're going to do scenarios. But in order for us to do what we need to do, we have to tell you what the tools are. What do we need to get this done? We need the 2023 CPT manual. The current year is highly recommended. It's not required, but highly recommended. So if you don't have 2023, it's okay. Just download this handout. It's in your handouts. These are the CPT guidelines. Yeah, so it's in your handout. Go ahead and take them. And if you have the MCG manual, it's not required, but it's recommended. And finally, writing utensils. Now, here are the goals of the presentation. Number 1, we're going to learn how to CHUN the E&M section. Number 2, we're going to discuss office visits. And 3, MDM, medical decision making. And finally, we're going to talk about 2023 changes during weeks 2 and 3. All right, let's get started with office visits. We're going to get right to it, and we're going to learn how to CHUN office visits, code series 99202 through 99215. All right, so here is a replica of your book. And don't feel like you have to take notes while you're in session. You can do it after when you see the playback, all right? So it's probably more important that you get the instruction rather than write down every detail. All right, so here's how I'm going to chun it. I'm going to box straightforward medical decision making for 99202. This is office or other outpatient visit for the evaluation and management of a new patient, which requires a medically appropriate history and or examination. And this is for a straightforward MDM, and the total time of the encounter is between 15 to 29 minutes. And I'm also going to document these keywords right outside of the code, the time and the MDM. Now I'm going down to 99202. This is a low-level medical decision-making encounter, and the time is 30 to 44 minutes of total time spent on that date of the encounter. 99204, this is the code for a new patient. I forgot to say that. New patient, moderate level of medical decision making with a total time of 45 to 59 minutes spent on the date of the encounter. And finally, 99205, this is the code for high level of medical decision making with a total time of 60 to 74 minutes of total time. Now let's take a look. We know this is a new patient code series, and you also notice that 99201 has been deleted and you are directed to report 99202. And below in the parenthetical guideline, it says for services 75 minutes or longer, go ahead and use prolonged services code 99417. And the final thing that you need to make note of, there's no more history, exam, and Well, there is medical decision making, but no longer a HEM, HEM. That is gone. So our documentation or our CHUN is going to reflect that. So we're not documenting a HEM, we're just documenting the total time of the encounter and the MDM. All right, so now that we've looked at a new patient and how those codes look, let's take a look at established patient. And we'll start with code 99212. This is an office or other outpatient visit for the E&M, or the evaluation and management of an established patient, which requires a medically appropriate history and or examination. So you don't need a history and exam. It's a history or exam or both. And this code 99212 is a straightforward medical decision making with a total time of 10 to 19 minutes spent on that date of encounter. And I'm going to document it. The time is 10 to 19 minutes with straightforward medical decision making. Code 99213. This is the code for low-level medical decision making with a total time spent 20 to 29 minutes. And 99214 is a moderate level of medical decision making. Total time 30 to 39 minutes. And 99215, this is high level of medical decision making with 40 to 54 minutes of total time. And then look below, you see the parenthetical guideline that says for services 55 minutes or longer, use prolonged services code for 99417. And I didn't forget 99211. This is a code for the clinical team. Sorry about that. For the clinical team, such as the nursing staff, RNs. And don't confuse that with nurse practitioners or advanced practice nurses. All right, so I am going to start a little slow because I understand that some people haven't really, since certification, they really haven't studied E&M, but trust me, we are going to pick up the pace, but I want to do right by everyone here. So if you will, please allow me. Now, I'm going to answer the question, what are E&M visits? An evaluation and management encounter, pretty much visits, office visits, inpatient hospital visits, emergency department visits, consultation visits, nursing facility visits, and home visits. They're office visits. All right. So it's not an encounter as if you were getting, well, a lot of times when we hit evaluation and management, sometimes we forget that doctors need to be compensated for their services. So E&M codes for those visits rather than the services, those surgeries, etc. So I'm just going to make that nice and neat. Now, in your CPT manual, somewhere around Roman numeral 25, depending upon your year, there are tables in there. How many of you have ever used these E&M tables? Go ahead, type in the chat. All right, so some of you probably have, and some of you probably haven't. But I want to bring your attention to it because these are going to be very helpful. They're going to be very helpful in getting that correct E&M code. And I just decided, hey, why not use them? It's going to make your process simple, and that's what we're here for. So on the screen, you see two tables. They both are for office or other outpatient services, but the one on the left is for the new patient. The one on the right established patient. I'm not going to go over how to use it, but I am just bringing it to your attention. Also, in the front of your book, come on, you got some more charts. You have inpatient hospital or observation care and subsequent hospital or observation care charts. You also have admit and discharge on the same day chart, as well as inpatient consultations. You have office consultations, emergency department services, and below you have initial nursing facility care and subsequent nursing facility care. Also, you have home visits, new patient and established patient home visits. And finally, critical care. Yes, you have neonatal pediatric critical care, intensive care. You got a chart that's going to help you code more accurately. So, what do you mean by that, Mrs. J? Well, I want to show you. Let's get into it and let's learn how to select an E&M code using these charts. But before we do that, we have to review the elements that you need to do so. So you're going to have to answer the following questions when you are solving an E&M code. You're going to have to answer, is this a history and or exam? What is the location of the visit? When I'm saying location of the visit, where is the patient seeing the doctor or the doctor visiting the patient? Or what location in the E&M section that you're coding for? Also, the type of visit. Is this a new visit or an established visit? Is the patient new or established? 4, the total time of the visit. If the doctor documents the total time, great. If they don't, then we'll have to determine what is the MDM, the medical decision making. Number 6, then you'll use the E&M tables to select the code. And don't forget to apply all guidelines. I'm going to make that number 7 because it's so important. All right, so I've got a scenario. And this is going to be a total time scenario, so we're not going to talk about medical decision making for now. And I'm just going to walk you through this, all right? So you can solve it if you want to, but I'm going to walk you through it just for the sake of time because we're going to do these scenarios with a purpose a little later, all right? Patient arrives to the physician's office for follow-up of hypertension treatment. The physician carried out a medically appropriate exam and spent 30 minutes working up the patient. So I'm going to solve it like this. I'm going to answer these questions. I'm going to say, was a history and or exam carried out? And then I'm going to look at my documentation. And yes, a medically appropriate exam took place. So I'm going to say yes and check that off. Next, what is the location of the visit? So where did the patient visit the doctor or the doctor visit the patient? Or where can you find the code in the CPT E&M section? Well, my documentation says this is a physician's office visit. So the location of the visit, office. I'm going to check that off. Number 3. What type of visit is this? Is this a new patient or established patient? Well, the documentation says this is a follow-up. Follow-up visits are indeed established. So we're going to check that off. And we said we're going to determine, well, the scenario will be determined by the total time. So we're going to look to see what is the total time spent for this encounter. And our documentation says 30 minutes. So we're going to document that, check it off. Now we're not going to solve this scenario based upon the medical decision making. So we're going to just kind of put a line over that. And we are going to use the E&M tables to select the code and apply all guidelines. So let's go ahead and use that table. So which table are we going to use? Well, if you look below where it says 1, 2, 3, 4, 5, hopefully you can see my pointer. It says the location of the visit is office. So we're going to get that office or other outpatient services table, right? Also, this is an established visit. So if it's established, we're going to use the established chart, right? So let me make it a little bigger so we can see it. The total time of the encounter is 30 minutes. So I'm going to show you how to select the code using time and this evaluation and management table. All right, so all you do is go to the bottom of the chart where it says total time on date of the encounter, and then just select your minutes. We're looking for 30 minutes, and it's somewhere right in here. And then you just scroll up and find your code. It's 99214. That is the code for this encounter, this 30-minute encounter of an established patient. So hopefully you'll see how, I don't know if it's going to make a big difference or not, but it is an option. I like it. I hope you like it too. Now we've looked at a scenario based upon the total time. We obtained the level of service. Now let's look at a scenario based upon the medical decision making. And yes, it's the same. You need to answer the same exact questions. So let's get started. The patient arrives to the physician's office for follow-up of hypertension treatment. The physician carried out a medically appropriate exam with low medical decision making. All right, so we switched out the 30 minutes of time for low MDM, and we're just going to go ahead and reaffirm that a history and exam took place. The location of the visit is office. The type of visit is established. We're not going to discuss total time of the encounter because we are discussing the medical decision making, which is low according to our documentation. And then we're going to use the E&M tables to select our code, then apply all guidelines. So let's get our chart and let's get going. All right, so we're going to use the same exact chart, but what we're going to do different, we're going to start up at the top. The required elements is you must have a medically appropriate history and or exam. And it turns out we have one because our documentation says so. And next, I'm going to look down for my medical decision making. My MDM is stated as low in the documentation. So I'm just going to go over until I see my X. There's the X. I'm going to look up, and my code is 99213. And there you have it. That's pretty much how to use those charts. So if it works for you, it's an option. I encourage you to use them. Now, we're going to get started in our discussion, and we're going to talk about office visits. We're going to talk about guidelines right now. And the first guideline that we're going to direct our attention to is establishing whether or not a patient is new or established. And here are the guidelines. And as you can see, they're all green. Yes, all green. That means that there was some revision to the guideline, or there is a new guideline, but pretty much we have revision because you see the inverted triangles. All right, so just so you know, the E&M guidelines overview in the front right before the E&M codes on the green pages. Did you know that those guidelines are pertinent to the following? Only to the following: office or other outpatient services, hospital inpatient and observation care services, consultations, ED, nursing facilities, home or resident services, and prolonged services with or without direct patient contact on the date of E&M services. A lot of people didn't know that, so I thought I would point that out. But let's go ahead and let's start with the beginning. Well, the beginning of learning and understanding E&M. And what is that, you might say? Well, determining the classification of the patient. Are they new and or established? You can't be both. Are they new or established? And right here where it says new and established, it means this is where the guidelines live. This is how you know if a patient is new or established. So a new patient is one who has not received any professional services from the physician or other qualified healthcare professional, or another physician or other qualified healthcare professional of the exact same specialty and subspecialty who belongs to the same group practice within the past 3 years. So, in other words, that patient should not have been seen by anyone in that practice of the exact same specialties and subspecialties. Fair enough. And a lot of you have already known that. Now, that's a new patient. Either they're new to the practice or they haven't seen anyone. An established patient is one who has received professional services from the physician or other qualified healthcare professional, or another physician or other qualified healthcare professional of the exact same specialty and subspecialty who belongs to the same group practice within the past 3 years. And it tells you, see the decision tree for new versus established patients. And we are going to do that, but not now. And finally, here's another guideline. It says in the instance where a physician or other qualified healthcare professional is on call or covering for another physician or other qualified healthcare professional, the patient's encounter will be classified as it would have been by the physician or other qualified healthcare professional who is not available. When the advanced practice nurses and physician's assistants are working with physicians, they are considered as working in the exact same specialty and subspecialty as the physician. All right, so that's a mouthful, I know, but let's go ahead and that was for new and established patient. And I'm going to revisit new and established patient very soon. But I do want to draw your attention to initial and subsequent services. So a lot of people just kind of use the same definition for new and established and initial and subsequent. They are not the same. The guidelines are here. And pretty much, I'm just going to say the major difference between the two is the 3 years stipulation, right? So new and established says, hey, you had to have seen this patient within 3 years, or you're new if it's beyond 3 years. Initial and subsequent service does not specify a time that you should have seen the provider. However, a new, okay, I'm just going to go ahead and read it really quickly. Let me go here. An initial service is when the patient has not received any professional services from the physician or other qualified healthcare professional or another physician or other qualified healthcare professional of the exact same specialty and subspecialty who belongs to the same group practice during the inpatient observation or nursing facility admission and stay. So you see that language really is it's specific, but it does not include that 3 years. And we're going to look at this guideline closely the following week. So it's going to be a really interesting conversation. All right, so what is a new or established patient? In sum, a new person, a new patient is new to the practice and they haven't seen the physician within the past 3 years. An established patient was seen within 3 years, and any doctor in that practice of the exact same specialty and subspecialty has seen that patient. Here's my scenario for the visual. For my visual folks, I'm visual too, so this might help. All right, so you've got Dr. A and Dr. B. Dr. A and B are both oncologists who work for Oncology Associates, LLC. They're both oncologists. But Dr. B advanced his studies to include neuro-oncology, right? So, my question to you is Dr. A and B, are they of the exact same specialty and subspecialty? Go ahead and type in the chat if you think they are of the exact same specialty and subspecialty. All right, I'll give you a moment or two, and the majority of you are saying no, they are not. You're absolutely right. Dr. A is an oncologist. Dr. A's specialty is oncology. Dr. B's specialty is oncology. However, Dr. B has a subspecialty of neuro-oncology, whereas Dr. A does not. So they are not of the exact same specialty and subspecialty. Now, let's talk about this decision tree that CPT directs us to. And this decision tree helps us determine if a patient is new or established to a practice. So let's go ahead and say a patient's name is Amy, and they're an established patient of Dr. A's. Then, for whatever reason, Amy decides that she wants to see Dr. B, who is also in the same practice. We need to determine if Amy is new or established. And sometimes that might be an easy, you know, answer, and sometimes it isn't. So in this case, let's say it isn't easy. All right, so we have to answer these questions. Did Amy see a doctor in this group of the same specialty within the past 3 years? And that's, yeah, the answer is yeah. All right. So both Dr. A and Dr. B are in the same specialty, excuse me, in the same group, and they are of the same specialty. So we're going to say yes. All right. Oh, I apologize. So I apologize. I got a little ahead of myself. No, I didn't. All right. So here's the next question. The next question is, was it the exact same specialty? And it is. They're both oncologists. So yeah. Is it the exact same specialty? Well, excuse me, exact same subspecialty. Remember, Dr. A is an oncologist. That's his specialty. Dr. B is an oncologist, but his subspecialty is neuro-oncology, and it is not the exact same specialty. So we're going to say no. So because they don't have the same subspecialty, Amy is a new patient. So Amy is new to Dr. B. But, and this is a guideline found under new and established patient, if the doctors are covering for one another, let's say Amy happens to see Dr. B because Dr. B is covering for Dr. A, the classification would be the same as the physician covered for. So she would not be new. She would be established. All right. And the guideline is there. We've just read it, but just to remind you, it's under new and established patient. So that is how you determine if a patient is new or established. And hopefully you understood that guideline about doctors covering for one another. And last point I want to make, qualified healthcare practitioners are physician's assistants and advanced practice nurses or nurse practitioners. The guideline also says that when they are working with the physician, they are of the exact same specialty and subspecialty as that physician. All right, so I'm going to let that marinate. I know I said a mouthful, but we got a lot to cover. All right, so let's go ahead and review. Got a question for you. All right, true or false? A new patient is one who has not received any professional service from a physician or qualified healthcare professional within the past 2 years. Go ahead, put your answers in the chat. Okay, that chat is raining, and the answer is one moment. All right, that answer is false. Outstanding. All right, we got another question. True or false? If Dr. B, a dermatologist, is covering for Dr. A plastic surgeon, for an established patient visit, patient will be classified as a new patient. True or false? Go ahead, type your answer in the chat. All right. Some of you knocked it out of the park, and some of you are going to have an aha moment. And the answer is false. Yes. So if Dr. B is covering for Dr. A, remember the guideline that said, hey, if you're covering, the classification would be the same as the physician covered for, right? So if this is an established patient originally, it will continue to be an established patient. Very good, everyone. All right, so now let's get to our discussion. And yeah, we're going to still talk about office visits, but we're going to learn how to code it with the guidelines in mind. All right. So, in this part of the discussion, we're going to talk about office or other outpatient visits, and then we're going to focus our attention on scoring the medical decision making. All right. So, I think I should ask, let me know, how do you feel about scoring the MDM? All right. Just type in the chat. Do you feel good? Are you leery of it? Just whatever word or descriptive you want to say, go ahead, type in the chat, let me know. And then I'm going to continue. So we're going to talk about office visits. And if you didn't know, for 2023, the doctor can choose whether their documentation is based on total time or MDM. In fact, this began in 2021. Yes, but 2023, they have further clarified several of the guidelines. So let's get into it. Total time of the encounter or MDM. And we've just performed two scenarios, one total time, one MDM, but we didn't do it with the guidelines. So let's go ahead and review the guidelines for selecting the level of E&M service or code based upon time. Yeah, there's a lot of guidelines in there. All right, so under the section where it says guidelines for selecting level of service based on time, that's where you'll find it. And specifically in this section below, that's where you're going to see the activities that are the activities that the guidelines stipulate that a physician or qualified healthcare professional should carry out when they are performing E&M services in office visits, and it's based on time. Okay, that was a lot. But what they're doing in the office when they see the patient, these are the activities. Now, let me go ahead and just kind of bring it up on the screen so you can see it a little more clearly. And this is what a doctor can do when the doctor has an office visit with a patient. They can use the time when they are preparing to see a patient, such as reviewing their chart, reviewing tests, etc. Obtaining or reviewing a separately obtained history, performing a medically appropriate evaluation, exam or evaluation, counseling and educating the patient, family, or caregiver, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals when it's not separately reported, documenting clinical information in the electronic health record, independently interpreting results not separately reported and communicating those results to the patient, family, and or caregiver, and finally, care coordination, which is not separately reported. So if they can report anything separately, if there's a code for it, they cannot include it in their time activities. Now, what they cannot claim, separately reportable items, just what I just said, travel time, nope. In general teaching and not management of a specific patient. Often providers will come in when they do rounds in a doctor's office or in a hospital. If they are teaching and not really managing that patient, then they can't claim it. All right, so here are the approved CPT approved time-based activities. Now that we know these approved times, let's go ahead and let's reveal what you should be highlighting. What are the key words you need to highlight in documentation? And yes, we're getting ready to solve time scenarios with a focus on those guidelines. So what you need to highlight: the age of the patient, diagnoses, signs and symptoms, exams, procedures, or anything the doctor does, total time of the encounter, medical decision making, and any data that the provider reviewed. So these are some things you should highlight. Why are you highlighting them? You're highlighting them so that you can answer these questions, the questions we've just sort of reviewed. What is the history or exam? Did a history or exam take place? Where is the location of the visit? What type of encounter is this? What's the total time of the visit? What is the medical decision making? And then we'll use E&M tables to select the code, and then we'll apply all guidelines. So these are the questions that we need to answer when we're solving an E&M scenario. Now, when it's based upon time, we're not going to consider the medical decision making. So let's cover that up, and let's go ahead and let's test our knowledge. And I'm going to ask Miss Tamika to come to the fore. Our intern called out. So, Miss Tamika, please, and thank you.
Thank you, Mrs. J. All right, coders, here we go. What are the E&M CPT coder codes reported? A 37-year-old female patient with a history of dyslipidemia and chronic pain arrives to her PCP's office for follow-up of lower extremity swelling. The patient indicates that the swelling responded to hydrochlorothiazide. Limited exam was carried out and her labs and echocardiogram were reviewed. The patient does have moderate pulmonary hypertension. The final diagnostic assessment is that of bilateral lower extremity swelling improved with diuretics. This may be secondary to pulmonary hypertension, but the etiology is not clear at this time. So we'll do a workup and possible referral to a pulmonologist. The plan. I think we'll need to evaluate the etiology of the pulmonary hypertension. The patient will be scheduled for a sleep study. The total time of this encounter is 30 minutes. And again, what are the E&M CPT coder codes which should be reported? All right, coders, you have 1 minute and your time. It starts now.
All right, time's up. How did you do? How did you find this? Was this, were you able to kind of figure it out? I think a lot of you have. I do. But I really want to kind of empower you to know and understand how this should be done. There is a process. All right. So my keywords: 37-year-old, dyslipidemia, chronic pain, follow-up, lower extremity swelling, limited exam carried out. Her labs and echocardiogram were reviewed. There were bilateral lower extremity swelling, pulmonary hypertension, and the total time of the encounter was 30 minutes. So let's go ahead and let's do our due diligence by answering the questions on the top right. Did a history and or exam, medically appropriate exam, take place? And you might say, well, what is medically appropriate? Medically appropriate right now is at the determination of the provider. So the provider determines if it's medically appropriate or not. So you can best believe that if they carried it out, they're going to think it's medically appropriate. So for the sake of this presentation, we're going to assume that the doctor carried out a medically appropriate exam if they've documented it. Now, in the real world, you might have some stipulations that you'll need to follow. And of course, those will take precedence over these instructions. All right, so medically appropriate exam was carried out because it says a limited exam took place. That's medically appropriate, so we're going to say yes. Now, the location of the visit, where is this visit? And it says that it's an office visit. In fact, it's in her PCP's office, and that her PCP is an indicator that a relationship has been established. So this is an office visit and it is established. And just think about it. It's new if the documentation says it's new or it meets that criteria. It specifies the criteria for a new patient. And that's what we're going to go with. All right. An established visit will always be the default if it's not documented. All right. Total time of the encounter. Well, it says it's 30 minutes. So we'll document that. We are going to get rid of the MDM because we're considering this documentation based upon total time. Now that we understand these time guidelines and the physician activities, let's go ahead and see if our provider meets the guidelines as they pertain to physician activities when using time to establish the level of service. So one of the things they say is the provider can use time to perform a medically appropriate exam or evaluation. And we did have a limited exam. So based upon number 3, we can go ahead and select the code using time. And also, just to kind of be more thorough, this provider carried out a sleep study. So if you look down, the provider ordered a test, and that is a permitted activity as well. So let's go ahead and get to it. We're going to look at the codes. We got a 30-minute encounter. This is an established patient. I'm going to go find the code for a 30-minute established patient, and that's going to take me to 99214. Total time of that encounter has to be within 30 to 39 minutes, and that's our answer. So I know some of you got that correct. I know you did. That chat is flying. There's no way I can interact or engage with it. You're moving too fast for me to see you, but I know you're doing an amazing job. All right, so if you got that correct, outstanding. If you learned something, that is priceless. Now, let's move on to scenario number 3. Oh, okay. Before I do that, let me just show you the chart. If you're getting used to that chart or you want to get used to it, you just go ahead and find on the chart the total time. In our case, this is an established patient visit. At the bottom, total time is 30 minutes right here. And we're just going to go up and find our code, 99214. Now, we got another scenario. Miss Tamika, please and thank you.
My pleasure, Mrs. J. All right, coders, we know you're up for number 2, so here we go. What are the E&M CPT code or codes reported? A 14-year-old female patient with a history of cystic acne arrives to her dermatology oncology initial visit for treatment. She was referred by her general dermatologist who belongs to the same practice. The provider carried out a comprehensive history and exam and reviewed the patient's chart, which contained a comprehensive metabolic, renal, and thyroid panels with a skin biopsy. The final diagnostic statement, chronic cystic acne. The total time of the encounter is 60 minutes. All right, coders, your time of 1 minute It begins now.
All righty. I know you all are rocking that chat, but let's go ahead and see how we solve this scenario. All right, so our key, if you want to know what that is at the top where it says highlight, that's just a reminder of some things that you probably should highlight. You have your 14-year-old patient, history of cystic acne, dermatology, oncology, initial visit. She was referred by a general dermatologist of the same practice and who carried out a comprehensive history and exam and reviewed this comprehensive metabolic, renal, and thyroid panels along with a skin biopsy. The final diagnostic statement is chronic cystic acne with a total time of the encounter being 60 minutes. And below, just as a reminder to the right, these are the questions that we need to answer. And we're going to eliminate MDM because we have a total time, but we need to make sure that this encounter is eligible. So let's look at the approved activities, and we see right here that a medically appropriate exam is enough that was carried out. And number two was also a comprehensive history as well. But we need only one, and it's eligible. So let's go ahead and answer the questions at the top. We know a history and or exam was carried out, right? Comprehensive. So yes. What is the location of the visit? Well, this is a dermatology oncology initial visit. And if there's no documentation saying that the patient was inpatient, then they are indeed outpatient. So an outpatient visit is often an office visit or clinic visit. Number three, what type of visit is this? Is this new or established? Well, it says this is initial, right? And it says that this patient was referred by her general dermatologist, right? She was not, this dermatologist was not covering for the other, but referred. So we're going to say it is new. Also, total time of this visit is 60 minutes. We're not going to consider the MDM. We're going to apply all guidelines and we're going to use the E&M tables to select the code. So the first table that we're going to use, it's not really a table, but we're going to use the codes. We're just going to go ahead and find our visit. And if you look at the new patient codes, look down, find 99205. This encounter is 60 to 74 minutes. And this is our code, 99205. So it's that simple. So if you nail if these first four items, then you can answer that code and confidently know that the code is correct. And for those of you that are starting to get familiar with the chart, let's go ahead and solve it using the chart. This is a new patient visit, 60 minutes. You just go below, locate 60 minutes, scroll up, your answer, 99205. And for those of you that weren't sure about whether this was new or established visit, again, go ahead and answer the question. Did this patient receive any professional services from the physician or qualified healthcare professional or another physician or qualified healthcare professional in the same group with the same specialty within the past 3 years? And she has, because she's being referred by her general dermatologist. She had to have seen the general dermatologist. So she saw someone in that group, and the answer is yes. Is it the exact same specialty? Absolutely. Both doctors are dermatologists. Is it the exact same subspecialty? And that's where we're going to say no, because the dermatologist that she was referred to is a dermatology oncologist. So we're going to say no. And that's how we know that this is a new patient visit. All right, so hopefully you understood that. And I'm going to hand it over to Miss Tamika for our third scenario. Thank you, Miss Tamika. Take it away.
Again, my pleasure, Mrs. J. And coders, you guys are really doing phenomenal in the chat, and we are just excited to see what you're doing. So we're going to move on to scenario 3 now. And what is or are the E&M coder codes reported? Susan is a 67-year-old female and is referred by Dr. R with a suspicious neoplasm of her left arm. She's had it for about a year, but it's grown a lot these last few months. I had the privilege of taking a skin cancer off her forearm last year. Her past medical history is that of hypertension and arthritis. There are no allergies. Her medications are Benicar and Vytorin. Her social history is that of no cigarettes. Her physical examination consists of a raised lesion. It is a little bit reddish, and it's on her left proximal arm. It has a little bumpiness on its surface. Medical decision making is that of a suspicious neoplasm of the left arm. My guess is that it's a wart, but it may be a keratocanthoma, as Dr. R thinks it is. After obtaining consent, we infiltrated the area with 1 cc of 1% lidocaine with epinephrine, performed a 3 mm punch biopsy of the lesion, and then I shaved the rest of the lesion off and closed the wound with 3-O-Proline. We'll see her back next week to go over the results. The total time of the encounter is 55 minutes. And once again, coders, what is or are the E&M coder codes that should be reported? You have 1 minute and your time. It starts now.
All right. Thank you so much, Miss Tamika. You are incredible. Thank you so much for being in the chat too. And she's telling me that you all are doing amazing, and I know. All right, so let's go ahead and solve this scenario. We're going to highlight our keywords. And also, did you notice we're only giving you a minute? Yep. That's exactly the amount of time that you should be able to spend on these total time encounters. All right, so you've got a 67-year-old female referred by Dr. R, suspicious neoplasm of her left arm. It has grown, this is his observation, grown a lot these few days. He had the privilege of taking cancer off her forearm last year. Past medical history, hypertension, arthritis. On her examination, she had a raised lesion, a bit reddish, left proximal arm, little bumpiness on its surface. The medical decision making, suspicious neoplasm left arm. All right, so the doctor guessed this is a wart and it may be keratocanthoma. I wish I could say that. She said it so nicely. All right, and 3 millimeter punch biopsy of the lesion, and then the doctor shaved the rest of the lesion off and then closed it. The total time of this encounter is 55 minutes. All right. So, because we don't have a lot of room, let's go ahead and review the time requirements, the activities that a physician can do. And, we don't have to go through them all for the sake of time, but this doctor did obtain and or review a separately obtained history when he said that she had this condition for about a year, and it's grown over these last few months. He obtained that information from the patient, and it's in this section right here. This is the history. And remember, the history is what the patient says to the doctor about their condition. Also, we know that the doctor performed a medically appropriate exam, right? In this section right here, it says physical examination. All right. So that did take place. Now, let's go ahead and answer these pertinent questions. Was there a history and or exam? We already said there was a history and an exam. What is the location of the visit? Now, coders, there is no location specified. However, we can deduce that this is not inpatient, right? No. If it was inpatient, it would have specified that. If there's no specified location and the patient is seeing a doctor, it's a doctor visit, the default will be office. But that's going to bring us to number 3. What type of visit? Well, we know that this patient was referred by Dr. R, right? But this doctor saw this patient last year. So this patient was seen within 3 years. So this is an established visit. And finally, the total time documented is 55 minutes, and we'll document it and get rid of the rest. Then select our code. We're ready to select. And 55 minutes for an established visit is 99215. But if you read the parenthetical note inside, it says for services 55 minutes or longer, see prolonged services 99417. So I'm going to go ahead and look at that code 99417. And this is prolonged outpatient evaluation and management services, time with or without direct patient contact beyond the required time of primary service when the primary service level has been selected using total time, each 15 minutes of total time. Okay, you know what? That's a little much for me. It's a lot of words and it's kind of confusing. So I prefer to use the prolonged service chart. Yes, there is a chart in your manual, and I'm going to go down and I'm going to locate the prolonged services for office and other outpatient chart, established patient, and then I'm going to look at my time. Anytime between 55 and 69 minutes. I'm going to code it like this: 99215 one time and 99417. And that is our code. But if you are in the business, you know that you would have had to code those procedures. 11104, 113, and 11104 is your punch biopsy, followed by your shave technique, 11300 with a 59 modifier. And then your E&M codes, 99215 with a 25 modifier, 99417 with a 25 modifier. Or, and the reason why I'm coding it, because it says what is or are the E&M CPT codes. If this patient came in and had an appointment for the removal, I would not have coded those E&M codes. So there you go. All right, so I have a question. What happens if the physician doesn't provide the time, right? Because we're able to answer those questions in a minute, right? So what do we do? Well, we're going to have to answer it based upon the medical decision making. Remember, office visits can be determined by the time or the medical decision making, and it is up to the doctor. It is the doctor's discretion. So if he doesn't indicate time, then we will go ahead and base it on the MDM, and we're going to have to score it. So how do we score the MDM? Well, we're going to review the documentation, we're going to score the documentation, and we're going to select the level of service or code. And depending upon that documentation, it can produce a level of service that's straightforward, low, moderate, and high. Now let's go ahead and let's just learn how to score that MDM. And in your CPT manuals, you have a chart. It's green. I can't wait until it's black. I love this chart. I do. However, I love the AMCI PDR chart when you're learning. I love that more. So after you kind of get your rhythm and you understand how to score documentation, I encourage you to use this Table 1, Levels of Medical Decision Making, to score your documentation as your tool. But right now, I'm suggesting that you use the AMCI PDR chart, and that you can find them in the MCG manual, and there's a courtesy one in your LMS, which you'll have access to during the 4th week of this session. All right, so it looks like this, and we're going to use it very soon. All right, so what are we doing? What are we scoring? We're going to be scoring 3 things. We're going to be scoring the number and complexity of the problems. We're going to score the amount and the complexity of the data reviewed. And we're going to score the overall risk. And we call this the P for the problems, the D for the data, and the R for the risks. And let's take a look at the AMCI PDR chart. All right, so if you go to the top, you see your problems, and down below, you'll see the level. Level 2 is 1 self-limited or minor problem. Level 3 is low level, and they consist of, or here's some examples, or these are types of level 3 problems. It's 2 or more self-limited or minor problems, 1 stable chronic illness, or 1 acute uncomplicated illness or injury, or 1 stable acute illness, or 1 acute uncomplicated illness, or requiring hospitalization in patient observation level of care. All right, so that is your low. Your moderate has one or more chronic illness with exacerbation progression or side effects of treatment, two or more stable chronic illnesses, or one undiagnosed new problem with uncertain prognosis, or one acute illness with systemic symptoms, or one acute complicated injury. And level 5 is one or more chronic illness with severe exacerbation, progression, or side effects of treatment, or one acute or chronic illness or injury that poses a threat to life. So these are your problems. Your data and the amount and complexity of data, we are just going to take a quick view. Your straightforward is minimal, or level 2 is minimal or no data. Your low data level says that you have to meet any two of the following within category 1, or you have to meet category 2. Your moderate data says you have to meet 3 elements from category 1 and category 2, or category 2, or category 3. And high says you have to meet any 3 of the data within category 1 and or category 2 and or category 3. And now your risk. Your risk is straightforward, or level 2, when it's minimal risk of complication, low risk of complication of morbidity and mortality from testing or treatment. Moderate risk is moderate risk, and they give you some examples such as prescription drug management, decisions regarding minor surgery with identified patient or procedural risk factors, decision regarding elective major surgery without identified patient or procedural risk factors, diagnosis or treatment significantly limited by social determinants of health. And high, some examples: drug therapy requiring intensive monitoring, for for toxicity, decision regarding elective major surgery, decision regarding emergency major surgeries, decision regarding hospitalization or escalation of hospital level of care, and decision not to resuscitate or de-escalate due to poor prognosis. So it's going to fall under one of these levels. Your problem will be one of the level, your data will be one of the levels, and your risk will be the other. Then you'll go ahead and level it or score it, and then you'll select your final office visit code. So that is how you use the PDR chart. Now let's get to coding. All right, so how do you determine the MDM code selection? Based upon scoring the documentation the exact same way you do when coding for time. All right, so your history and or exam, location, type of visit, MDM, E&M tables, and apply all guidelines. Now, what keywords? The exact same keywords: age of patient, diagnosis, signs and symptoms, exams, procedures or treatment, total time, not the total time, medical decision making, data reviewed. Now, are you ready to test your knowledge? All right, Ms. Dolly, take it away.
Thank you, Mrs. J. All right, what is the E&M CPT codes reported? A 37-year-old female patient with a history of dyslipidemia and chronic pain arrives to her PCP's office for follow-up of lower extremity swelling. The patient indicates that the swelling responded to hydrochlorothiazide. Limited exam was carried out, and her labs and echocardiogram were reviewed. The patient does have moderate pulmonary hypertension. Final diagnostic state assessment: bilateral lower extremity swelling, improved with diuretics. This may be secondary to pulmonary hypertension. Etiology is not clear at this time. We'll do a workup and possible referral to a pulmonologist. Plan: I think we will need to evaluate the etiology of the pulmonary hypertension. The patient will be scheduled for a sleep study. Okay, everyone, you have 2.5 minutes to solve.
Thank you, Miss Dolly. All right, so as we're getting those answers in and our time is winding down, so I want to make sure we get this discussion everything in. All right, so let's go ahead and highlight our keywords. We have a 37-year-old female patient. I think that's going to come. Dyslipidemia, chronic pain, follow-up, lower extremity swelling, limited exam, labs and echocardiogram were reviewed, bilateral lower extremity swelling, pulmonary hypertension, evaluate the etiology of the pulmonary hypertension. The patient will have a sleep study. These are my keywords, and 37 is going to pop up somewhere. There it is. All right. Now you might say, Mrs. J, this looks familiar. It should. We scored it based on time before. Now we're scoring it based on the MDM. All right. So we've already answered these questions, but let's go ahead and do it again. Was a history and exam carried out? Yep. A limited exam. The location of the visit. This is the PCP's office, so it's an office visit. And it's her PCP, so it's established. We're not going to consider the total time, but we are going to talk about the MDM. And how do you do it? Well, you list your diagnoses and your procedures. And the procedures also include what the provider did or is going to do. Then you pull out go ahead, let's go ahead and put our diagnoses here. This patient has dyslipidemia, chronic pain, lower extremity swelling. Now, let's go ahead and pull out our chart. Oh, we got one more. Pulmonary hypertension, etiology unknown. Now we're going to use this chart. And the first thing that we're going to determine are the problems. And if you look at the top, it says number and complexity of problems addressed. Addressed is key because if you look at your list, dyslipidemia, while the patient has dyslipidemia and chronic pain, those two were not addressed at all in the documentation. No, just the lower extremity swelling that the doctor linked it to pulmonary hypertension. So that leaves us with two. So we know it's not a straightforward problem. And I don't think it's a low problem. I'm pretty sure it's a moderate problem because I think of the selections, this circumstance, pulmonary hypertension with lower extremity swelling, falls under I would say one or more chronic illness with exacerbation. That is my selection. All right. So it falls under moderate problem, level 4. And so because it's a level 4, I'm going to assign this a level 4. So coders, tell me what you have. Did you score it as a level 4? Let me know. All right, so now we're going to turn our attention to the procedures or what the doctor did or is going to do. Well, the doctor carried out a limited exam. The doctor reviewed labs, didn't say the number of labs, so we'll just say one lab, one echocardiogram, and scheduled the patient for a sleep study. So I'm going to say this falls under a level 4 data. So in order to assign it a level 4, you must satisfy one of the categories, category 1, 2, or 3. And it satisfies category 1. Category 1 says you have to have 3 of the following. So the provider ordered a unique test, each unique test. So the doctor ordered one sleep study, that's the unique test, And the doctor also reviewed the results of a unique test, the results of a lab, and the results of an echocardiogram. So that's 3 elements met. So we do meet level 4 data. So I'm going to put the 4 up the top. And now the risk. Risk is a little more subjective, and I give it a low risk from of morbidity and mortality. Here's why. Because to assign a moderate risk, they give us some examples. Medications prescribed, a decision for minor surgery, decision for elective major surgery, and diagnosis or treatment significantly limited by social determinants of health. So I don't have any of that. In fact, this patient is going to be evaluated after a sleep study. No medications was prescribed. They did say that the patient's condition improved with diuretics, but the doctor didn't manage it. All right. So I'm going to give it a low risk, and that's a 3. However, like I said, the risk is a lot more subjective. And as a coder, you say, hey, I think this is a level 4. Go ahead, assign it a level 4. And if you do, you're going to come up with the exact same score as me. Now, because we have a situation where we have a level 4 problem, a level 4 data, and a level 3 risk, we have to level. Because when your PDR, your problems, data, and risk, when they're not an exact match, you're going to have to level to get your code. So how do you level? You throw out the lowest level. Our lowest level is 3. Then you code the next lowest level. We only have 4, so our answer is moderate. So if you said, hey, I think that's a moderate risk, you wouldn't have to level. All of your elements of the PDR match, so you would just have selected a moderate level. So our answer is moderate, and we know it's moderate, and we know it's 99214 because the code for an established moderate patient is 99214. Just look to the right and you'll select your answer. All right. How are you feeling? You doing good? Excellent. All right. So some of you might say, hey, Mrs. J, you're moving a little fast. Always know you're going to have access to this playback. All right. So we're ready for our next scenario. Miss Dolly, take it away.
Thank you again, Mrs. J. All right, what is the E&M codes reported? Susan is a 67-year-old female and is referred by Dr. R with a suspicious neoplasm of her left arm. She has had it for about a year, but it has grown a lot these last few months. I had the privilege of taking a skin cancer off her forearm last year. Past medical history is hypertension, arthritis. Allergies are none. Medications are Benicar and Vytorin. Social history is cigarettes, none. Physical examination is, on examination, she has a raised lesion. It is a little bit reddish and is on her left proximal arm. It has a little bumpiness on its surface. Medical decision making is suspicious neoplasm left arm. My guess is this is a wart, but it may be a keratoacanthoma, as Dr. R thinks it is. After obtaining consent, we infiltrated the area with 1 cc of 1% lidocaine with epinephrine, performed a 3 mm punch biopsy of the lesion, and then I shaved the rest of the lesion off and closed the wound with 3-0-proline. We will see her back next week to go over the results. What is the E&M codes reported? Okay, everyone, you have 2.5 minutes to solve.
All right, thank you so much, Miss Dolly. Okay, so our keywords, the same as before, 67-year-old referred by Dr. R, suspicious lesion of the left arm, skin cancer off the forearm last year, hypertension, arthritis, suspicious neoplasm left arm, 1 cc of 1% lidocaine and epinephrine, 3 millimeter punch biopsy, shaved the rest of the lesion. Those are the key words. Oh, we don't actually code close the wound closures. So let's get started. All right, so let's go ahead and answer our questions on the right. The patient had a physical exam, so yes. The location of the visit, we established that this is an office visit. There's no indication that it is inpatient, so it's outpatient. The type of visit, we established previously that this is an established patient because this doctor removed the cancer off the forearm last year. So the doctor saw the patient within the last 3 years, even though the patient was referred by Dr. R. Established. We're not going to consider the total time of the visit. Sorry about my line. Now we're going to just talk about the MDM, and we have to inventory. So let's go ahead and inventory our diagnoses. Signs and symptoms. This patient has a history of hypertension, arthritis, and the medical decision making or the final diagnosis is suspicious neoplasm. The procedures, what is the provider going to do? Or if there were any procedures carried out. Indeed, there was a 3 millimeter punch biopsy along with a shaved lesion. Now let's go ahead and turn our attention to the problems. What are the number and the complexity of the problems addressed? Well, we don't have hypertension. Hypertension was not addressed. It's just a part of the past medical history. And so too is the arthritis. But that suspicious neoplasm, that is the only problem addressed. And I scored it. Go ahead and tell me what you scored it as. Go ahead, type in the chat. Did you say moderate and why? I said moderate, and I'm going to tell you why I said moderate. Because this patient has a suspicious neoplasm. Now, what is acute and what is chronic? Well, chronic means that this condition can last more than a year or for the life of the patient if treated and or not treated. And a neoplasm indeed is chronic. Definitely. This patient has a history of skin cancer, so we know how chronic a lesion can be. So the reason I selected this level 4, this is a chronic illness with progression. Yes, it has grown a lot. So it's a level 4. Hopefully you understand. Or I'm sure there may be another option too. But if you scored it a moderate, good job. Now, the data, there was absolutely no data, right? So I said minimal data. The doctor just basically used their own discretion and they moved forward with the risk part. So I gave it a level 2 data. And the risk, what did you score? Is it a 2, 3, or 4? Well, if you said 4, outstanding. We had decision made regarding minor surgery. Minor, right? Not only was there a decision, it took place. So we've got a 4 problem, 2 data, and 4 risk. So that means our PDR does not match. So we're going to have to level, right? And how you level? You throw out the lowest and you code the next. So we've thrown out 2 and we code the level 4. And that means, because this is an established visit, look, it says new visit. This is an established visit, 99214. All right, so how do you feel? All right, because we don't have so much time, I do want to get to some more. And I believe this is yours. Is this yours, Mr. Sandeep?
Oh, the next one is mine, Mrs. J.
Okay, so I will read this. Thank you so much, Mr. Sandeep. All right, Miss Dolly, I believe this is yours. Go ahead, take it away.
Thank you, Mrs. J. All right, what are the E&M CPT codes reported? A 14-year-old female patient with a history of cystic acne arrives to her dermatology oncology initial visit for treatment. She was referred by her general dermatologist, who belongs to the same practice. The provider carried out a comprehensive history and exam and reviewed the patient's chart, which contained a comprehensive metabolic, renal, and thyroid panels with a skin biopsy. Final diagnostic statement is chronic cystic acne. What are the E&M CPT codes reported? Okay, everyone, you have 2 minutes to solve, and your time starts now.
Okay, thank you so much, Miss Dolly. You were amazing. All right, so now my keywords: history of cystic acne, initial visit referred by her general dermatologist, who belongs to the same practice, comprehensive history and exam, reviewed the patient's chart, the comprehensive metabolic, renal, thyroid panels, and a skin biopsy. Final diagnostic statement: chronic cystic acne. All right, we're just going to get right to it. At the top, we've already answered these questions. If you can recall, this was a comprehensive history and exam, so our answer is yes to history and or exam. The location of the visit: it is an initial dermatology oncology visit. No mention of inpatient, so it is office. The type of visit: is it new or established? It is indeed new, because it's an initial visit. And this doctor, although in the same practice, is not of the same subspecialty. And then we're going to just go ahead and score the MDM. So what are our diagnoses? Chronic cystic acne, we have one. And sorry, I got a little ahead of myself, but I scored this number and complexity of problems addressed as low. And the reason, this is one stable chronic illness. I'm going to let that marinate for a second. So do you agree that this is one stable chronic illness? You agree or not? It is chronic. It's in the diagnosis, okay? So it's stable because there's no medication, or the documentation doesn't indicate that it's unstable. Okay? All right, so let's go ahead and look at our procedures, or what the provider did or is going to do. Well, did a comprehensive history and exam, reviewed the comprehensive metabolic panel, the renal panel, thyroid panel, and the skin biopsies. So we're going to go ahead and get rid of the history and exam because you really don't have to document that. So what data did the doctor review? So I'm looking, and I think we meet a level 4 because we have 4 data. Well, 3 data reviewed and 4 data reviewed. So this requirement says you must meet 1 category below. Category 1 was below. The doctor reviewed the results of each unique test, and all 4 tests are indeed unique. So we satisfy category 1. And finally, the risk. Oh, sorry, that's a level 4. And finally, the risk. I scored it straightforward. Minimal risk of morbidity and or mortality. This is acne. Yes, it is cystic acne. Yes, it's chronic, but minimal risk. That is my that's my opinion. That's my coder's opinion. Somebody else might say, hey, I think it's low. Go ahead and assign it low. It is subjective. So I gave it a 2. The PDR do not match, so we have to level. I'm going to throw out the lowest, and that leaves us with the next lowest. And this is a 3. Low problem, level 3. I'm going to go to the right, look for the new code for level 3, and that's 99203. So did you get that answer? I hope you did, or if you didn't, I just hope you're starting to understand this scoring process. Now, really quickly before I hand it over to Mr. Sandeep, you might say, well, how do you know if something meets a specific category? How do you know, Mrs. J? Well, the key to success in MDM scoring is understanding those definitions. And in your handouts, I've provided an MDM. Well, this is the AMA definition. Well, the guidelines are there as well as the definitions. And these definitions are in your CPT manual as well. So if you have a 2023, your definitions of the problems, the data, your risk, all there. Okay. Also, they go more specifically, they get right down to the nitty gritty, and they define what a problem is, what a problem addressed is, what a minimal problem is, a self-limited or minor problem, a stable chronic illness, an acute uncomplicated illness or injury, an acute uncomplicated illness or injury requiring hospital, inpatient, or observation level of care, your stable chronic illness with exacerbation, progression, or side effects of treatment. You should read that one because we're using it a lot. undiagnosed new problems and uncertain prognosis, acute illness with systemic symptoms, acute complicated injury, chronic illness with severe exacerbation, progression, or side effects of treatment, acute chronic illness or injury that poses a threat to life or bodily function. These are the definition for problems. Your data is also defined. What's analyzation? What does analyze mean? What do tests mean? What does unique mean? Combination of data elements. What does external mean? What does external physician or other qualified healthcare professional mean? What does discussion mean? What is an independent historian? What is independent interpretation? And what is an appropriate source? And finally, risk. Very short, but these are the definitions. So if you want to know what risk is, here's the definition: morbidity, social determinants of health, surgery, whether it's minor surgery or major surgery, drug therapy requiring intensive monitoring for toxicity. These are all defined. So it would be, it's a great idea to go ahead and take a look at those guidelines. Again, there are your time guidelines, unlisted services guidelines, and anytime you use an unlisted code, you will need a special report. And again, your table 1 of your levels of MDM are here. Now it looks like that we may run over just a bit. If you have to leave, go ahead. Just know that you will be able to watch this in the playback. All right, so are you ready to test your knowledge again? Now that you have the definitions, the AMA definitions, feel free to utilize them. And I'm going to ask Mr. Sandeep to come to the fore, as well as Miss Jasmeet. Take it away.
Thank you, Mrs. J. Ms. Jasmeet, can you please read the scenario for us?
Absolutely, Mr. Sandeep. Thank you, Mrs. J. Thank you, Mr. Sandeep. Okay, scenario. Established patient office visit. DOS 5th of 9th and the year. Chief complaint, left tibia fracture, history of present illness. Patient is a 13-year-old male we first saw on 4th of 24th, and the year is not mentioned. He was noted to have been injured when he jumped and fell while running down a hill. He sustained a Salter Harris 2 physeal fracture of the distal tibia. He is currently non-weight bearing in a short leg cast. He has been compliant with his activity modifications. Physical examination. He is intact to sensation. His capillary refill of the toes remains stable. There is no skin breakdown at the proximal or distal aspect of the cast. The cast is intact. Ancillary studies or radiographs are ordered, performed, and billed in our office of the left ankle, May 8th, 20 something, show good alignment and positioning of the fracture. Growth plate is stable. Impression, left distal tibia fracture. Plan, he will continue with the use of his cast, maintain non-weight bearing status, return for reassessment with new x-ray in 2 weeks. Cast care instructions are once again being reviewed. What E&M code is reported? Coders, you have a minute and a half to solve the scenario. Thank you.
And that coders is 1.5 minutes, and I can see from the chats you're doing a good job here. So let's start and solve this scenario by highlighting our keywords. We can see this is an established patient, and we are having office visit. It's a 13-year-old male, and the patient has suffered from a Salter Harris 2 physeal fracture of the distal tibia. There is a physical examination done, and we have a radiograph ordered, and it showed a previous radiograph. It shows a good alignment of the fracture. Growth plate is stable. Impression is going to be left distal tibia fracture, and again doctor has ordered for an x-ray in 2 weeks. So that's all the highlighted keywords which we are having. Now let's move on and let's solve this scenario by using the questions which we are having. Before that, let's see the ICD which we are having, the diagnosis which we're going to code here. Okay, there is a physical examination performed. Whether there is a medically appropriate history, yes, there is a history done. There is an exam as well as performed. So that's a tick mark, yes. Next question, where is the location of this visit? You can see it's been documented. It is an office visit. And there comes the third question, the type of visit, whether this is a new patient or an established patient. Well, that's also documented here over in the top. It's an established visit. So no time is documented. So what we are going to do is that we are going to score the MDM. And we are having a diagnosis of left tibial fracture. Okay, now next let's see our PDR charts and let's see where this fits under the problem column. So we can see I would take the patient, since the patient is having a left tibial fracture, this is going to be an acute uncomplicated illness or injury, and they have given the definition as well, a recent or a short-term problem with low risk morbidity for which the treatment is considered. Example also has been given, cystitis, allergic rhinitis, simple sprain. So the fracture, I would take it under acute uncomplicated illness, and that would be a low level problem. Let me see. Yes, that's going to be a level 3 problem under the P. So next our job is to look the data and what the doctor has done or what he is going to do. We can see that he has performed the examination of the cast, ordered the radiograph, and also he has read the previous radiograph. So that's going to fit into the low as well. Under the data, we can see the order of each unique test. Okay, there goes 1 point, and we have a review of the result as well, of the unique test as well. So 2 points. It goes under level 3 for the low data. So we have got problem under level 3, data under level 3. Next job is to look into the risk column, and let's see where this fits. This is a fracture, isn't it? Patient is having a left tibial fracture. So this is not going to be a straightforward or a minimal risk. So I would suggest to take it under a low risk complication. It doesn't fit the moderate as well. So that's, I think it's a perfect match to go with the low risk. So that will become under level 3 in low risk. And we have got a straight line here. We have problem, data, and risk all coming under low, and our MDM, there's no leveling required here since we have all under low, and the MDM will be also low, and that is going to be 99213 because this is an established patient. So how do you feel, coders? How do you feel about this scenario? Yes, most of you have got this correct. And let's also cross check in our CPT book under 99213. This is an office or other outpatient visit, and we are having which requires a medically appropriate history, examination, and most importantly a low level MDM, medical decision making, which we figured out by using our PDR chart. So good work, coders. Good work in this scenario. Let's move on and let's look into the next scenario. Ms. Jasmith, can you please read this scenario for us as well?
Yes, absolutely. Thank you, Mr. Sandeep. New patient office visit. Chief complaint, low back pain with radiating pain into the legs. History of present illness, a 78-year-old female with long-standing back pain. She is noted to have undergone previous epidurals. She has been diagnosed with spinal stenosis for approximately 10 years. She denies bowel or bladder dysfunction or saddle anesthesia. She offers a weakness of the extremity and numbness. She offers no unexpected weight loss, no recent trauma. She denies previous back surgery. She is a new patient to our office. Current medications: lisinopril, lovastatin, glipizide, arimidex, naproxen, Neurontin, Xalatan, multivitamin. Allergies: codeine. Past medical history: breast cancer, hypertension, diabetes, prior history of spinal stenosis. Review of systems: denies any cardiac arrhythmia or unstable angina, no pulmonary disorders, denies thyroid disease, no renal dysfunction, no history of stroke or seizure. She is without any unexpected weight loss or constitutional signs of infection. Social history: she is ambulatory without assist device, denies tobacco and alcohol use. Family history: diabetes and cancer. Physical examination: side-to-side comparison shows no asymmetry, no pronounced atrophy. She has a pronounced straight leg raise on the right and also a contralateral straight leg raise on the left, but her discomfort is to a lesser degree. Reflexes are symmetric. Motor strength is noted to be 5 on 5 with ankle, doris, and plantar flexion, great, great toe extension, knee flexion or extension, hip abduction. She has 4 of 5 motor strength with hip flexion. Her hips are supple on examination. She has decreased sensation to L5, L4 to L5 level. Ancillary studies: independent interpretation of previous MRI from the hospital, November 20 something, shows evidence of spinal stenosis at L3 to L4, L4 through L5, and 5 to S1. There is a neural foraminal narrowing at these levels. Findings are most noted at L4 to L5. In addition, there is a facet hypertrophy and ligamentous thickening. Cord maintain a normal signal. Impression: spinal stenosis with radicular leg pain. Plan: a repeat of MRI will be obtained. She will return for reassessment following this study, likely begin another course of epidural steroids. I have also recommended physical therapy. Further recommendations are pending her MRI. What E&M code is reported? Coders, you have a minute and a half to solve this scenario. Thank you. Oh, looks like you have 2 minutes and a half to solve the scenario.
Okay, coders, that's 2.5 minutes, and it's scenario 8, and you guys are totally comfortable while level taking the level using the PDR chart. I can see that from your answers. So let's go ahead and highlight the keywords here. It's a new patient. It's an office visit. The patient is having a low back pain with the radiating pain into the legs. And it's a long-standing back pain diagnosed with spinal stenosis. And she's a new patient to our office. Past medical history, we are having breast cancer, hypertension, diabetes, prior history of spinal stenosis. So except the spinal stenosis, I'm not going to consider the other condition because it is irrelevant to the current visit. It's not getting treated here. So I will just concentrate on the low back pain and the spinal stenosis here. And we are having a data review. We're having independent interpretation of the previous MRI performed here, and the final impression is spinal stenosis with a radicular leg pain. And in the plan, doctor has planned for a repeat MRI and likely begin another course of epidural steroids. And he also recommended a physical therapy. Now let's go ahead and solve the scenario. Yes. So we are having our questions here. Are we having a medically appropriate history and exam? Yes, you can see we are having a medical appropriate history documented and physical examination as well. So that's a big yes there. And second question, what's the location of this visit? Where was this visit conducted? And it is also documented. It's an office visit. And type of visit, a new or established. This is a new patient. It also documented that she is new to our facility, new to our office. So this is a new visit. And time documentation, there is no time documented here, so we are not going to consider that. And next step, level 5, step 5, we are going to score the MDM here. So we are having a diagnosis which is a spinal stenosis with radicular pain, and the procedures performed. Did what did the provider do, or what he is going to do? There was an independent interpretation of MRI performed at the hospital done, and he has also ordered an MRI, a repeat MRI, as well as there was a discussion about the epidural injection. So he has planned also for another course of epidural injection. So this is all the documents, data which we are having here. And it's time to score the MTM using the PDR chart. So where does it falls under problem? Where does this diagnosis, the spinal stenosis, falls? Well, you have seen the patient was having the low back pain, the spinal stenosis for a long time, and it's also documented it's been there for approximately 10 years. So that is a chronic condition, and spinal stenosis is also a chronic condition, and the patient was having this condition and it was not getting reduced. The patient is still having the problem, so that indicates it's an exacerbation. So this, I would take it under moderate problem, level 4. So it would be chronic problem with exacerbation. So there we go. We have got a moderate problem, level 4. Next, our duty is to look under data. So what all the doctor has done, you can see there is an interpretation. There's an independent interpretation of the MRI performed at the hospital. But well, that alone will take us into the moderate data. Also, we have a repeat MRI as well as performed, but the independent interpretation of the test performed by another MD, qualified healthcare professional, that alone will take us to the moderate data as well. So we have got a level 4 data here, and next we have to figure out the risk. So what the doctor is going to do, what he has planned for a, let me look, he has planned for an epidural injections. So this is a steroidal epidural injection. Steroidal, by the way, it's a prescription drug. Moreover, the epidural steroidal injections are considered to be a minor surgical procedures. So that will take us into the moderate risk level 4 here. So yes, that is level 4. So totally we are having a moderate problem, a moderate data, as well as a moderate risk. So again, in this scenario, there's no need for leveling. We are having a moderate level ENM, and that would give us the answer of 99204. So how are you feeling, coders? Yes, great work.
All right, we have reached the end of week 1. We made it. Outstanding. And many of you have done extraordinarily well. We are incredibly proud of you. Now,